You're welcome back on board. Sorry for earlier. Now we have two doctors in the house. We're going to be starting with Dr. Oni. She is a medical practitioner, and she has not less than 20 years experience in medical practice. Our topic for today is mental health in retirement, a focus on depression and generalized anxiety disorder. So without wasting much of our time, I would like to welcome Dr. Oni to speak with us. I will unmute her right now and then she will commence.
Thank you. All right, so good afternoon again, everyone. It's my pleasure to be in this gathering. It's always wonderful to be in the presence of retirees, and always a pleasure to be in the presence of people with a wealth of knowledge and experience. I'm hopeful that our discussion today will also shed more light on some areas of concerns that people tend to keep hidden and not want to share, but in some form or the other, way or the other, many of us may have experienced some of these conditions. So I will be standing in I'll be standing in for my director, who is a specialist psychiatrist, and he will also come into this discussion. He has a wealth of knowledge in this area. And but I'll just start off by giving us a bit of information, and I'm sure he'll be available for all our questions and answers at the end of the discussion. So we'll just start by discussing basically about depression. Like the topic says, we're going to that word depression. Many people don't want to say, it's not my portion or not. But in one little way or the other, many of us are experiencing some form of depression. It might even just be when you lose something that you like, or maybe if you lose someone you love, or if you just even going for an interview is a form of anxiety as well. So many of us experience different spectrums of these conditions, but because it doesn't stay long and we're able to get out of easily, many people don't recognize that you have undergone these conditions in a transient way. However, there are some people that tend to have a worse extent of the condition, and they may tend to stay longer in depression. As such, these are people that may require intervention, and there are some tips that we may give to guide and help people that may need to access care regarding this area. So retirement, by way of introduction, retirement, of course, is inevitable. Everybody will retire from one career, from one activity or the other. It's a natural transition in life, and especially the worker. Retirement will come. And as such, it's always good to prepare one's mind, not only physically, not only in preparing, what you will survive on and all that, but even emotionally. A lot of people go through some emotional transition when they hear retirement. It sometimes even comes with fear, because you wonder, have I put enough in place? Or how will I cope? Well, I'm used to this life already. I go out every day, come back every day. I'm used to this. What will I do in retirement? It is fraught with a lot of concerns and anxiety. So, it's good to know what we can do to help ourselves. So, unfortunately, many people, the thought of retirement will bring anxiety. It will bring some form of apprehension. And unfortunately, some people will go into some worse state of depression or anxiety disorder. So it's important for them to know that there are counselors, there are health professionals available to address this condition. And it's good not to demonize the conditions, because the truth is, it's not as much as we say it's a mental health condition, it doesn't mean that because somebody is depressed, the person is crazy. Our culture tends to demonize a lot of mental health conditions, but again, they are all just natural conditions, just like having hypertension or diabetes. There are conditions that can be treated, and if treated early, persons can always, recover and go back to normal daily activity and normal functioning. So from beginning of life, even coming into the world is stressful. If you've seen how a baby comes into the world crying, and even the process of pushing the baby out is a stressful experience for that child. So we know that our lives are fraught with stressful experiences from beginning to the end. Even a little child learning to walk, it has some little stress, but okay, I'm not getting it. Why am I not getting it? And then talk about now when we become adults, when we now go into a different phase in our life, where there are different things that may come to us. It's just life is full of all kinds of stressful episodes. However, how we react to the stresses is what is important. And so our way of responding to stress is what determines, or what differentiates us from people that have worst case of the health conditions. So I'll just stop here because I think my consultant is on ground and is going to take over from this point, and he will be starting with depression, and he will go further into what depression is. Thank you, ma'am, and thank you, everyone.
Okay, thank you so much, Dr. Oni. Very soon, we are going to have Dr. Kolade coming on board. Dr. Rashid Ade Kolade was born in Island Maternity on the 9th July 1970. He attended mainland nursery and primary school, Ikeja, and then thereafter proceeded to Ikeja Boys School. He did his A-levels at Kwara Polytechnic in Ilorin, and he graduated from University of Ilorin in January 1999. He did his housemanship at the General Hospital, Ikeja, between year 2000 and 2001. He is presently the director at the staff clinic, and he majored in he's a specialist in psychiatry medicine. Please, he is married.
Let me just extend my apology for coming late or shifting the lecture twice. It was just beyond my power. I was at Vero to attend a mental health program with the First Lady. So I want everybody to accept my apology for that. Good morning, everybody, ma. Good morning, ma. Good morning, sir. Hello, ma. Hello.
They are here. They are on mute.
Okay, ma.
That's
Sorry,
why
can we share this? So I want to share this slide with everybody, ma. What I did is that since I'm speaking to the retiree, so we need to get some things, and we need to really link what retirement has to do with mental health, because there is difference between mental health and mental health disorder. We all have mental health. That is when you are normal. You start what you expect in the new future, you are going future, because now you got it. civil servants used to. So with all this going in you, a lot of thoughts that will just mix in all these things I've mentioned. At times, some people may become depressed along the way. So next slide, ma. The next one. Next. Oh. The next. Okay, ma. Okay, ma. No, go back. You've gone twice. Okay, no, go back a little bit. Okay, ma'am. Okay, ma'am. You can see that right from the time of birth till the last breath drawn, individual is invariably exposed to various stressful situations. The modern world, which is said to be a world of achievement, is also a world of stress and has been called age of anxiety and stress. This is just to buttress what I've said in the previous slide. So naturally, when you are born, it's all throughout until the last breath on earth. So the next slide, let's now go to depression. Let's talk about the main topic of today. You know, when you talk about depression, what does it mean? What are the presentations? What are the signs and symptoms? What are the causes? What are some of the things? And how can you cope when you are depressed? So next slide. So for depression to be diagnosed, there are some key factors, 3 signs and symptoms. But I need to talk about the biography of it, which we can find. You can see from this slide. A mental health disorder characterized by persistently depressed mood or loss of interest in activities causing significant impairment in daily life. When you're talking about depression, we are talking about disorder that has to do with the mood, your mood, what your mood is like all throughout the day. Are you on the joyous side? Are you on the other side? So, but in depression, there will be a mood, and also it will be supported with loss of interest in pleasurable activities. This simply means for somebody who is not happy, you find out that maybe it's somebody that loves watching movies, he loves going out, around that period, the person with the loss of interest in all these pleasurable activities will be well noticed, and it will be affecting the daily life of that person. This is a feeling of severe despondency and dejection. It is a common but serious illness. Like most people don't know, depression is a very serious illness. And from the cause of a suicide, the first cause of suicide is depression, and that is what? That is the last resort that comes out of depression. But for depression, you can see in the lifetime risk in males is between 8 and 12%. Lifetime risk in females is between 23 and 26%. But for the major depression, we have 80% of the total population. Then it has been found that by 2023, the commonest disease by 2030, will be psychiatric manifestations of all these disorders. Then typical depression episode can be diagnosed after 2 weeks. We are going into that. Then depression is the among leading cause of disability worldwide. You know, post-COVID. Even we can't say post-COVID because we are still in the COVID era. At least we can see a lot of people, even during this COVID, we found out a lot of people being depressed, committing suicide, and all those things. Next slide, please. Next slide. Hello, ma. Hello. Next. Next slide, please, ma. Okay, let me just keep. The next slide is going to talk about what are the causes of depression. But when you're talking about the causes of depression, there's a way we group them. We have the biological, which can as well maybe under the genetic. But the first thing in depression is the family history. That is why we found out the genetic or hereditary. Most of these illnesses in psychiatry, they run in family because the potential of somebody who has a father, a mother who has psychiatric illness, and he or she coming down with psychiatric illness is on the high side compared to the general population. Then that is when you talk about the biological, there are some things in the body we call the neurotransmitters, like the serotonin, dopamine, and all those things. They could be the lack of those things could lead to depression. Then so there are some dietary, that's why we talk about balanced diet. There are some diets you need to take that will give you almost of all these biochemical that the body needs. But if you are not taking them, obviously you can. Then there are a lot of environmental factors, environmental stroke, sociocultural factors. Like what we're talking about, maybe an example is retirement, the loss of the loved ones. Maybe like this 419, duping, and a lot of things. Sudden death of somebody that you so much like or you so much love. Maybe like a kind of you losing a lot of things or business crumping and all these things. All these things could lead to depression. So those are just the basic things we're going to talk. Let's now go into what depression really talks about. That is, what are the signs and symptoms we expect in a depressed person? There are three key factors when you're talking about the way we make the diagnosis. I've said it. You don't make the diagnosis of depression until after 2 weeks. Until after all those, I'll come to forms of depression later. So or let me just mention it because to me, for this lecture, it's not an academic environment. So that's why I just label, you have what they call the major depressive disorder. Like the one I've said, it's depression with either somatic or psychotic disorder. You have the dysthymic disorder or dysthymia. That one is more or less something you hardly see. That is not, then you have the major one. The major one that has the psychotic depression, like the one we said psychotic depression are the ones that will present with some signs of hallucination, delusions, irrational behavior, irrational thoughts. Then it could be a postpartum depression. That is when you see, I'm sorry to say, the Yorubas call it abisinwe. That you see it in women immediately, maybe few days or few weeks after delivery, they come down with this. Then we have what we call the bipolar affective disorder, where you have depression on one side and then mania on the other side, which those are the forms of mood disorder. They are rather forms of mood disorder, not depression. So let's go to the signs and symptoms because that is what I feel will be a benefit to this discussion. When we're talking about depression, we have our major signs and symptoms, and there's a way we classify, because we classify why diagnosing depression. We classify it into mild, moderate, and severe. And this depends on the number of signs and symptoms a patient is presenting with. But let me now just go into the major signs and symptoms you find in depression. Next slide, ma. The first thing we have said is the mood. What is the mood like on daily basis? We call it the sad mood. You find out that this person is always sad. Is always sad. he's never happy. Then alongside, you now found out that there'll be loss of interest in his or her pleasurable activities. Like somebody that loves in the morning, maybe he loves jogging or going to the gym, or somebody that you found out that oh, he's always listening to music or loves watching the what do they call it movie and all those things. All these pleasurable activities will be ignored. Then they get tired easily, easy fatigability. These are the three major signs and symptoms that could make you diagnose that somebody has depression. So, and it has to be at least for 2 weeks. So when you're talking about this, we now have ancillary signs and symptoms which you can use to group it to either mild. From that, the person may have decreased appetite or weight. There could be something they call the early morning awakening. That is, patients wakes up very early but looking tired, couldn't stand up out of the bed, was always could lie down on the bed for 1 2 hours without moving out of the bed. You found it in a depressed patient. Then there's what they call the downward variation, that is up and down. It is worse in the morning. Like I said early morning awakening, which you can just attribute that worse in the morning too. Then there could be something, mostly they have psychomotor retardation, but there are some depression you can see agitation. What this retardation means is that they won't be all that sharp movement, even in their talking. You can find them as if they're having slurred of speech. So this could be found in a depressed patient. Then for the cognition, majority of them they feel hopeless, no future, nothing. Then some of them will be helpless, thinking there's no help from anywhere. And the one that is the major one is the worthlessness. There will be something they call the guilt feelings. They might now be thinking, oh my God, who am I? I've not achieved anything in life. I'm not doing well. I'm not doing that. So that is the so-called. Then again, there will be difficulty in their thinking. Even to concentrate is the problem. Their memory in terms of immediate, short, and long terms are affected because they might not be able to even remember most of those things. Because in depression, loss of memory, which could be said to be dementia, masked in a typical presentation of a depressed patient. Then what of the suicidal risk, which is more or less the last resort, which I've said about in a major depressive episode. You found some of them because you could have, they are in 3 stages. We have what they call the suicidal ideation. They are just having the feeling. You have the intent. Somebody having the, wanting to do it. Then the final one is the real act, whereby they carry out the what's it called? The suicide. Okay, who are the people at suicidal risk? The unmarried, the divorcee, the widow, even the retirees. Yes, they are. Because by the time you retire, you just found out that most of the children that were at home when you were working, seeing them, most of them have graduated, they've started their own life, they've left you, maybe it is only you and your wife or your husband. You found out that everything is now lonely. So it could be a risk. Then one thing that is very common is they call it the suicidal note. It could be written or verbal. You have to be you have to take it. Then we have some physical symptoms along with it, which we may say the somatic symptoms, but it's generally aches and pains. Then we now have the final one we said we can have under the rubric of either mild moderate, or severe, which is the psychotic features. Hallucination. I'm hearing voices. I can see strange things. I can smell what people around me are not smelling. I can taste something that is not really there. I can feel something on my body. All these are hallucinating processes. Then you can now have delusion. Delusion, that is the false belief that somebody grips onto tenaciously, despite seeing the evidence that this thing is not like this. But mostly in depression, you found what they call the persecutory delusions. They are always claiming people want to kill me, they want to harm me, they become suspicious. Suspicious about almost everybody around them, thinking they are going to. So there is all behavior. You may have incomprehensible things. The next slide, ma. So what I've said now is you can now based on all these signs and symptoms I've mentioned, you can now talk about mild, moderate, and severe. So when you're talking about mild, the mild could be somebody having just those three symptoms and not having any of the auxiliaries, like I've mentioned, and just abruptly for 2 weeks. When you talk about moderate, moderate could have three of that, three or four of those ones on the other side: weight loss, loss of appetite, poor sleep, feeling worthless, hopelessness. But when you now talk about the severe one now comes in with what they call the psychotic features, which are the hallucination I've spoken about, the delusions, poor personal care. So when you're talking about depression now, we now go to how do we really investigate? But we found out that most of the psychiatric cases is through counseling, is through talking to, but there are some basic investigations. By the time you want to treat this kind of patient, you need to come into the PCV. You need to check about what is the level of the blood in this person. The urinalysis, you need to check the urine. You need to check the electrourea and creatinine because we are going to administer some drugs and injections. Obviously, all the organs, the liver, the kidney must all be in good condition. So let's now talk about how do you manage. The management of depression is basically and totally for the doctor to do. The first thing is biologically, we have some drugs we call the antidepressants, which we give to patients. And we have different classes of antidepressants. So they are of different classes. And then from there, you might need to add an antipsychotic. From what I've said, if a patient is severely depressed, you will need something that will tackle the hallucination I've spoken about, the delusions I've spoken about, and the irrational behavior that I've spoken about in the patient. This will be able to tackle all those ones. Then, there are some cases that even the patient will not even talk to you. He will refuse to talk to you. He will refuse to even do anything. He can sit, we call it, there's something they call, is a motto, is like, they call it a motor side effect of a motor presentation of depression. Do you understand? It is an automatic. They'll just station them. They might sit down and just gazing into the space. So in this kind of a situation, there's something they call the ECT, electroconvulsive therapy, that is being used, and they have people they use that for. There's this drug they call the lithium too. You use it to treat these patients. Then apart from that, the next slide, you talk about this psychological treatment, whereby the clinical psychologist is now the main man to now address this. You have something they call the cognitive behavior therapy. Because, like I said a depressed patient has negative thoughts. There's something they call the thought distortion. So the clinical psychologist needs to use the cognitive behavioral therapy in changing the mode on how this person thinks in order to bring in positive thinking and allaying the negative thoughts that have occupied the mind of this patient. So that is there are other forms of psychological treatment. In psychotherapy, you use the family therapy by bringing in the family. You can use the individual therapy. You can use the group therapy. These are majorly used for patients who are on the ward, who are admitted. So you bring them together. They share their experience. They share it among themselves. You use the experience of a patient to treat another patient. So you use that in group therapy. So you can even use, there are even some adherence therapy, because we found, okay, like they ought to be on maintenance dosage. But we found out that majority of them, after they might have gotten to a level, they now start saying they no more want to take medication, they stop the medication. The clinical psychologist needs to work on the psyche of such a person in order for the person to realize, to bring out, because there's something they call the insight. Most psychiatric patients doesn't have insight to their problems because they believe there's nothing wrong with them, since it's not a bodily injury or something they can obviously see. So they will argue with you that there's nothing wrong with them. And most of them are usually, so you can use all this psychotherapy to maneuver, to turn those their negative thoughts, to bring it back to the normal ways of thinking. So, and again, you can bring in the social welfare officers, which could corroborate either at their working place, with their family, or wherever these patients are. And in some bad cases, we can even invite the occupational therapist. Mostly somebody you felt is still young, he can walk. So why is this illness turning into somebody that cannot even do anything again? So you need to bring in that so that they can rehabilitate the person into the system. Next slide, please. Next, I think that's the major thing. The prognosis of depression is, I would say, is good if it can be identified early in life. If you can identify it early, those are the psychological. I've spoken about them: family therapy, interpersonal therapy, cognitive. Then let's now go to the major one that is common. It's very common and it's everywhere. We call it the generalized anxiety disorder. The next slide, please. Next slide, ma'am. So I think with that, we are done with depression. When we come to question and answer, I may still need to add one or two things. So next slide, you can see what they call the generalized. He's worried. He has no time. His job is occupying everything. You can see no sorriness, nothing. You can see that this person has everything that is just moving onto his head with them. So what are the challenges of a no? What is generalized anxiety disorder? I'll first define what anxiety itself is. Anxiety disorder is a mental health disorder characterized by feelings of worry, anxiety, or fear that are strong enough to interfere with one's daily activities. So if you're having anxiety to some form, it's normal. But the only thing that when it starts affecting you, your daily activities, it now becomes what? It now becomes a disorder. And we must know the difference between anxiety and fear. So when you're talking about GAD, which is the generalized anxiety disorder, it is an insidious onset. It starts gradually. It's not something that comes up just suddenly. No. And this thing is commoner, thank God, it's commoner in the 30s. Yes, it's commoner in the 30s. Though we can have it in the elderly. Then symptoms of anxiety must last for at least 6 months before you can call it GAD. From what I've said, is an insidious onset. Then the prevalence in the general population is between 2.5 and 8%. You can see that it's something that is so common, but most people don't take it to be an illness or a disorder. So it is the commonest psychiatric disorder in the population. You can see that. You can see what I've said about it. It is the commonest psychiatric disorder in the population. Then anxiety is a normal phenomenon. It only becomes pathological when it causes significant subjective distress or impairment in functioning of an individual. I'm very sure, sir, that this statement is well explanatory because I've told you that we all have tinge of anxiety in us. But if it doesn't disturb our daily activities, it doesn't disturb anything from us. So we can function well. It is a normal phenomenon. So it is not something we urgently need to see a psychiatrist or a clinical psychologist for. Next slide, ma. Next slide. So we're going to talk about some of the signs and symptoms we expect in person presenting with GAD. No. Next slide, ma. We'll talk about this later. So let's just look at the challenges of retirement when you talk about anxiety. That is, what are some of those things that could cause it, that could lead to it? So, but let's go to the signs and symptoms of anxiety. No, ma. Go back, ma. Okay, this is pre-retirement anxiety. Okay, let's talk about the symptoms first, so that we can then go to the pre-retirement signs and symptoms. You know, when you have anxiety disorder, you can it can be divided into motoric, autonomic, cognitive, and perceptual. So when you're talking about the motoric, that means what are the signs you can see that can affect the muscles of the body when you have anxiety? You find out that the person may have tremors, maybe in the hand, legs, even some have tremors of the mouth. Some may have tremors of the eyes in anxiety. Then there will be a form of very restless. They won't be able to sit down. They'll sit down, they'll stand up, they'll do this, they'll do. Then there could be muscle twitching. Just see that your muscle is twitching, as if they call it that in Yoruba, ori mi ndide, ara mi ndide. So something like that. Then there could be a fearful facial expression. You see it obviously, most especially people with panic disorder. You see it boldly on their face. Then when we talk about the autonomic, what about the autonomic system? They'll tell you they're having palpitation. That is, they can hear the way their heart is beating. Beat. Then you found out they're sweating, excessive sweating. Some will now become dyspneic. That is, they have difficulty breathing. Then some will complain of dry mouth, that they're having dry mouth. Some will complain of dizziness. And some, when the story has been told, you see them moving to the toilet every 5 minutes, having diarrhea. So those are the autonomic ones. Then what about the psychological symptoms? They find it very difficult to concentrate. They have poor concentration. They couldn't concentrate on on an event or a situation or anything they are focusing on. Then they are easily distractible. So instead of them, when you are doing this, by just doing one, they will be easily distracted. So then they can also be hyper arousal. So any little things, sure, yeah, they bang on it. Then they have lots of negative thoughts. Negative thoughts just coming up all the time into their thinking processes. Then the perceptual symptoms. There's something they call the derealization. That is, they start thinking about what they couldn't recognize the environment they are in. They feel the environment they are in is not where they should be. That is what they call the realization. Then they have the personalization, feeling as if they are not themselves. They start feeling as if they are not even like I'm Dr. Kolade now, and I'll start feeling as if I'm not the one, feeling as if I'm somebody else. So you can find out in them. Then they have some affective symptoms, just similar to the affective symptoms I've mentioned under depression. So these are all signs and symptoms. You see, have some of them. You can even have those ones that has to do with biological. But these are the major and the ones we focused on when somebody has the symptoms of anxiety. But from what we have said, you need to add it to. It has to be an insidious onset. Then it has to be there for nothing less than 6 months. That is when you start thinking about a GAD, because we have a lot of anxiety. We have phobic, panic, just name it. You have lots about that. So the next slide, ma. The next slide. So let's now talk about the psychological effects of the pre-retirement, although this is meant for people who wants to go into retirement. You can see that anxiety level unknown previously become very high as from 55 years of age. There is increased incidence of stress around that age bracket. Emotional balance becomes a regular struggle. Then nostalgia, depression is common. Even before towards that, you can have it. Then incidence of cardiovascular diseases is seen occasionally. You may have something, they have this panic attacks. Even some may come down with full-blown hypertension. Then future plans are uncertain. Next slide. Those are the psychological effects of pre. So let me just quickly mention, because most of the causes are not known, but we have a lot of theories that are being studied and being documented. We have the psychodynamic theory, we have the behavioral theory. This has to do with some of the behaviors that could lead to anxiety. We have the cognitive behavioral theory, like what I've said, your cognition, your thinking. What are you thinking? Thinking about the negative things, all this will be. Then we have the biological theory, whereby the neurotransmitters, they come in, maybe lack of serotonin, lack of dopamine, lack of noradrenaline, all those things. So those are basically the etiology of the causes of, but there's no, it's like I've said, clearly the causes are not clearly known. So let's go to the other slide. Let's talk about how can we cope and how can we manage this GAD. Next slide, ma. Okay, these are other forms of anxiety that I've mentioned. Phobic disorders associated with GAD. That is agoraphobia. There are some people, they call them agaraphobes. They have fear of places and situations that might cause panic, helplessness, or embarrassment. That is like when you're talking about agoraphobia, phobic patients, they find it very difficult staying among the crowd. They have phobia going into the society. That is that is what they are afraid. They are panicking. They are panicking, so they couldn't. Then you have what they call the social phobia, which is almost very similar, but this always occur in gatherings of social interactive sessions. So they have this irrational anxiety comes up when they are only in that gathering. Then you have the specific ones. Some people are, afraid of dogs. Is when they see dogs. Some is height. Some is water. So all these things could be associated with the GAD. So there are other forms of what they call anxiety. Next slide, please. Next slide, ma'am. Then what are the treatments? The treatment basically is psychotherapy. We have lot of forms we use which the clinical psychologists. Relaxation techniques is very important, very, very important. When you are dealing with people with TAD, you have the breathing techniques, you have other forms of, then there are a lot of other forms of behavior therapy. Then when you talk about the drugs, you have the benzodiazepines, you have something like you could use most of this, the Valium, nitrazepam, you can use what's this bromazepam and some other things. Then antidepressants could be used in these situations. They have found out they found out that they are very good. They could be very good in using them. Mostly you have the typicals and you have the atypicals. You have the SSRI. You have a lot of forms, which I think is going to be beyond the scope of this lecture. So when you're talking about all these things, these are things you can use, and which I found that majorly due to the fact of this COVID, a lot of these things has risen. Then we should be looking out for what they call the PTSD, post-traumatic stress disorder. That is what the psychiatrist will be battling with in the nearest future, because what it is going to be after COVID, what are the manifestations of psychiatric illness? So next slide, ma. Next slide. Next slide, ma. So because I have some tips that could be of help. So let's just quickly go, let us just talk about what is a healthy lifestyle. A healthy lifestyle is which it involves eating a balanced diet. That is first thing we must do, and mostly in the elderly is very important. Engage in a regular physical activity, not a, a vigorous one. Just get something doing, exercise yourself. Then obtaining adequate sleep and rest is very, very important. No matter what, when you are going into retirement, if you're going to set up anything, make sure whatever you want to do does not affect your sleeping pattern, because a very good regular sleep pattern is between 6 and 8 hours. Make sure that is not disturbed. Then balancing the demands of life with relaxation. That is, you may join any of the clubs. You may be even in the church. Just make sure you do things that will make you relax. Then please note that if more emphasis is laid on one area while neglecting another, this can result in stress, poor health, and the inability to cope with the demands of daily life. In addition, a healthy lifestyle also involves undergoing regular medical screening. Ma, sir, when last have you been to the hospital? How regularly do you check your blood sugar? How regularly do you check your BP? Then how regularly have you done some of the investigations that has to tell you the condition of your organs? All these things need to come into play for you to achieve a healthy lifestyle. Next slide, ma. Next slide. Okay, tips to adjust to retirement. Those are the tips. If you are the type that doesn't move anywhere, you can move within Lagos, not necessarily traveling out of Lagos. Stay active by doing the things you love. That is your pleasurable activities. Learn a skill, start a hobby. Cut your budget, reduce your expenses because you are now retired. No more salary, but the pension, which is usually a stipend compared to what you were collecting when you were in service. Get political, not necessarily joining a party, but at least you can watch through the TV, through the social media. Then you volunteer. Maybe if there are some things they need to do and they need volunteers, you can do that. Then you become a student. You learn a lot. Learn on the medical line, learn on transportation, learn on something, mostly outside your acquired profession. Then share your knowledge with people. Keep on working. Good diet, good social habits, then exercising. I think with all what I've said, it's something definitely we might have done. It's something definitely we are about to do. So just make sure you live a healthy lifestyle. Thank you, Ma. Thank you, sir. I hope we all enjoyed the little, I won't say lecture, the interaction between me and my moms and dads, my aunts. Thank you, ma. I'm done, ma. Hello.
Thank you very much, Dr. Kolade, for that very educative and informative lecture.
Thank you, ma.
I'm sure some of us have questions.
No problem.
Very soon we are going to be taking questions.
No problem.
But before we do that,
yes,
I want to quickly recognize some dignitaries in the house.
Okay.
We have the 20th head of service of Lagos State Public Service on this webinar with us, Mrs. Folashade Adesoye. Please let's put our hands together for her. We also have the former Auditor General at one time, and also former Accountant General. Mr. David Sumoni is also in the house. Please let's put our hands together for him. We also have some of my guys in the house. Let me recognize some of them. I have Mr. and Mrs. Lady Ju. I have Mrs. Alaka. She was one time the director of the service department. I see so many people. I also see Mrs. Kemisola Jiboye. our trainer at Magodo. Let's put our hands together for her. She's also on board with us. You are all welcome. You are very free now to ask your questions. You can just unmute yourself. And anyway, if you have questions, just indicate. Then we can ask you to unmute and ask your question. Questions? You can type if you don't want to speak. I'm still waiting. Questions? Do we have questions? I also see GOC. You are welcome, sir. We would like to hear your voice. Please unmute and speak.
Well, thank you, Dr. Our facilitator. It's a nice one. I joined along, but I benefited a lot. And I think I just want to add that most of us should not just retire and sit back at home. There's a lot of exercise you can do. Engage your brain, engage in actions, engage in politics, engage in anything that church activities and the like, so that you keep your body and soul together. We have really served, and we've engaged our life in the service. We can't just drop like that. Keep on being active, keep on working. Thank you very much.
Please, Mr. Fatade, we want to hear your voice. You are welcome.
Oh, thank you, madam. It's my pleasure joining you. Really, I joined just about 10 minutes to the end of the program,
Wow.
but in all honesty, I enjoyed the little bit that I met. I just want to thank the Office of the Head of Service, Civil Service Department for a job well done. Thank you, everybody.
Thank you, sir. Since we have no one asking questions, oh, I also see Mrs. Safu in the house. Please, can we hear your voice, ma'am? Please unmute and speak to us. Okay.
It's a privilege to be part of this lecture, or whatever you call it. It's quite instructive, and I hope that we have all learned from it what to take home in order to prevent depression in retirement. Thank you for Service Department, and thank you, Dr. Kolade.
Thank you very much, ma. Finally, we are going to take my mentor, my leader, the former head of service, the 19th head of service of Lagos State, Mrs. Folashade Adesoye. Please, we would like to hear your voice, ma. Please unmute and speak to us, ma. Thank you. Ma.
Okay.
Please, ma, unmute and speak to us, ma.
Hello.
Hello, ma. You're welcome, ma.
Thank you so much. I don't know what to say. Is it good afternoon or good day or good morning? Because I'm talking from, I'm in America now. I just want to appreciate the public service office, and especially your own department, for taking good care of us.
Thank you very much.
And also for Dr. Kolade, I think I really enjoyed the presentation, and
Thank
it is
you,
apt, especially for those of us who have retired. Most of us are just at home with our husband, or even those who have lost their spouses. They are just there, and they may be feeling very, very lonely. You know, all the children they have left. But as you have told us that we should consciously engage ourselves, if it is in the community or even in politics, we can engage ourselves in politics. We should be active anyway. We should be active. And one thing I just want to advise is that at our old age now, anything that will stress us, we should run away from it. Any investment that will bring stress to us, we should please run away from it. And we should check, we should visit our doctors, regularly. So on this note, I want to say that God will continue to be with us. We grant us long life to enjoy our children and our grandchildren, and also to witness those of you that are still in service, to witness your retirement. We shall all be alive to enjoy, to rejoice with you. My regards to the head of service, and for all my colleagues that are on this platform. I'm hearing Mr. Sumoni and others, GOC, long time. Let me show, maybe I should show my face, because this is a platform. GOC. So because I don't know when we are going to meet again.
Okay,
but
let me try and unmute everybody so that we can all be part of this.
Yes. I don't know when we are going to meet again, but I pray that we shall all meet in peace. And all other, Mrs. Afun and all others, Mrs. Lady Ju, we miss all of you. God will continually be with us. Those of you are still in those of you who are still in service, God will grant you wisdom to excel. And those who are still aspiring to become permanent secretaries, God will lift all of you up, and we shall rejoice with you. In Jesus' name. Thank you so much for honoring me. Thank you. Okay.
Thank you very much, ma'am.
That's okay.
On the final note, I would like to call on Mrs. Kemi Jiboye to please appreciate our facilitator for today. Before we round up, please unmute yourself. Please unmute. We are not hearing you, ma. Unmute.
I did before. Sorry, it went back. My hand touched it mistakenly. Okay, I want to appreciate the facilitator, Dr. Kolade, for the enlightening session. We're very grateful, very detailed, and you brought it on state by state so that we could easily follow. Even for those that are not in the profession, could easily follow what you told us. So we want to appreciate you. I want to say that by the mercy of God, the Lord God will strengthen you. The Lord God will empower you. And by the mercy of God, you never suffer any ailments. You never suffer any contrariness in your life. And with long life, God satisfy you in the name of Jesus. I want to appreciate the head of service, so former head of service. We appreciate you, man. It's good to see your face, man.
Thank you.
God bless you more and more. I just want to chip in something, if I may, before I thank Mrs. Dodola. As you were talking, I just discovered that some things that I started doing, I will now say, okay, I think this one, I think this one. Okay, I need to know this one and know.
Please unmute yourself, ma. What's happening? Please, we can all unmute. I've changed the setting now. Let's all unmute.
Yes. Aha. It was from your side.
Yes.
It was saying that you are not allowing us. Okay. I said I just saw that I started doing so many things. And I now saw that it was in order. Although I'm not stressing myself, I give myself space to do the things I do. I do Zoom training, free Zoom training, to share my experience with the world. Then, of course, on the pastoral side, I'm a pastor. I also share my experience on Facebook Live. So, I am busy, but not very busy. So I want to encourage us that we can, there are some things that come naturally to us. Like they have said, we can volunteer. I know some people, they is so common abroad, and I know that people do it here too. So we can look into what comes to us naturally. That's what just came to my mind. And then, start to share experience with people. It might even be mentoring, something that will engage us and make us feel relevant and have our self-esteem and sense of self-worth in place. I just wanted to add that one to it. So I wish everyone success and God's blessing. I want to thank Mrs. Drojola, Director of Post-Service, for always, inviting us here. I know you are doing a lot of extra work to invite us here, and I want to believe that by the mercy of God, God will continue to strengthen you in Jesus' name. Amen. So I say bye-bye, everyone, and God's blessings. Thank you, Samas.
Thank you very much, Mrs. Kemisola Jiboye. I want to use this opportunity to thank the Almighty God for making today a possibility. I think today is a lot better. No background noise. I think I'm getting the Zoom thing right now. I also want to say a big thank you to the Lagos State government for approving this program for the Lagos State Public Service retirees. I want to say a very big thank to the head of service and also to the PSPSO. He's usually on board with us, but today he has gone to represent the head of service somewhere. That explains his absence. I want to say a very big thank you to Dr. Kolade, Dr. Oni, and my entire team in post-service department. I want to say a very big thank you. And to the Lagos State Public Service retirees, I want to say a very big thank you to all of you for always coming back. I want to especially appreciate the 19th head of service. She is always coming back, always encouraging us. Thank you so much, ma. We are really very grateful. This is
28, not 19, or 28.
Oh, sorry, 28. I'm sorry, ma. 20th head of service, ma.
Thank you for
correcting me.
Thank you,
Thank you, ma. This is a bi-monthly program, twice in a month. We usually have one for health and the other one finance and business related. So in another 2 weeks, we are going to be inviting you to join another session. Until then, stay stress-free, exercise, enjoy yourself. Thank you for coming on board, and God bless you. Have a wonderful day. Bye-bye to everyone.
Bye.
Yeah.
Bye. Thank you.
Bye.
Thank you.
Bye.
Bye-bye.
Bye.
EOC.
Bye.
EOC.
HOS.
EOC.
Bye.
Okay. Oh.
Bye.
Okay. Bye-bye.
Thank God.
Bye.
Bye, everyone.
Bye, all. Bye,
It's
all.
very nice to be here. Thank you for this.